All right, everybody, welcome. I have 1 o'clock. Thank you for being here. I'm glad you can see the slides. Again, unfortunately, I can't see your comments right now, so if you have any questions, please just shout out. All right, and if somebody writes something in the chat that I can't see, please ask on your classmates' behalf. So again, welcome to our last review. Again, this is going to be a little bit of a review on our last 2 lectures, which again are examples of using all the concepts that we described throughout the early part of the course and applying it to both the musculoskeletal system and some of the general features of the male reproductive tract and the pathologies therein. Whoops. Okay. So just again, as an overall summary, if we think about, what are the parts of the musculoskeletal system, I have them listed here. But some of the key things that, again, when we think about the pathologies associated with the musculoskeletal system, some key important features to remember, again, is that bone, as you see, is not a static tissue. It is constantly remodeled. So again, disorders that affect the remodeling system can be prevalent. There's a little difference in when we refer, at least in the area of bone, to what we describe as dysplasia versus dysostosis. With dysostosis meaning simply there is absolutely completely normal bone deposited, it's just anatomically in the wrong place. And dysplasia, on the other hand, is the deposition of inappropriate sort of structural bone. As we will see in the musculoskeletal system, we see a number of congenital and acquired disorders, but unlike things like we saw in the GI tract, actually inflammatory conditions are common, but very few of them are as a result of infections. And then, of course, we have a number of growths that are both benign and malignant. Again, as a bit of a review, I tried to pull some of the things together from the overall part of the course. We have a number of congenital anomalies that can be found within the musculoskeletal system. These are typically inherited as mutations, usually as autosomal dominant or autosomal recessive disorders. And not surprisingly, because they are inherited disorders, the dysfunction is going to present itself very early in life. So often these are associated with a lot of what we call the pediatric disorders. And I've listed here some of them that we talked about earlier in the course, like Marfan's and Duchenne's, but some of the new ones to add to this lecture on musculoskeletal include things like achondroplasia or dwarfism, osteogenesis imperfecta, and osteopetrosis. Okay. In addition to congenital disorders of the musculoskeletal system, we have a number that are acquired in life. And so these sort of diseases typically are going to manifest later because they take some time to show clinical dysfunction. And not surprisingly, they are often as a result not of an inherited genetic mutation, but typically disruption of metabolic function in the bone, most commonly an imbalance between osteoclastic and osteoblastic activity so that the normal bone remodeling process is disrupted. So here are some of the examples that are new to this lecture were osteoporosis, osteomalacia, Paget's disease, hyperparathyroidism. Some of the things we thought before, lead lines and basically fractures, obviously are things that are acquired bone diseases. And some may occur, of course, in a background of an autoimmune dysfunction. All right. So again, with regards to inflammatory conditions of the musculoskeletal system, again, these typically present a little later in life, and they're not the standard as a result of infectious pathogens, but rather these are usually occur most commonly in the musculoskeletal system as inflammatory reactions in various joints. And these often have, again, their very distinctive clinical presentations. So I'm sure you remember the difference between particular things like osteoarthritis versus rheumatoid arthritis, where there is fusion of bones. Other common inflammatory conditions of the joints include things like gout. Occasionally, we see infections in the musculoskeletal system as things like infectious arthritis, myositis, or osteomyelitis. And as case studies show, again, the problem with infection in these regions is that because of the poor vasculature, they're hard to cure, but again, probably because of the poor vasculature in the first place, it's hard for pathogens to seed into these regions. So here we're showing you some pictures. Again, the difference between osteoporosis, or typical osteoarthritis, where there's just sort of degeneration of the joints, where rheumatoid arthritis is associated with fusion of joints and severe, again, dysfunction in joints. Likewise, in the musculoskeletal system, we have a number of tumors that are benign as well as malignant, and then some growths that would, at least initially on presentation, appear to be tumor-like, but in fact are not bona fide tumors. Probably what you saw in looking at the lecture was that with regards to bone tumors, they more preferentially occur in males than in females, so and often in sort of more younger males. And of the benign, I've tried to list all the benign ones that I could remember. We have osteomas, osteoblastomas, giant cell tumors, chondromas or osteochondromas, being again benign tumors of cartilage that may be within the cartilage or within the bone region. The synovial joints, the leiomyomas, lipomas, and fibromas. And of course, then we have malignant counterpart cancers of these same tissue types. And the growth-like sort of tumor-like inclusions include things like typically cysts or fibromatoses, nodular fasciitis. And I'll show you some pictures here again of some of these things. So for the purposes, again, of thinking about this in a pathological condition, you can imagine, again, where you have common symptoms where people may show up with pain in their bone or pain in their joints. So it's important to be able to differentiate, is this an inflammatory condition? Is it some kind of growth-like condition? Is it a dysfunction of bone metabolism? So again, like we've seen in other areas of the body, people presenting with a number of musculoskeletal disorders can have rather generic and common symptoms, such as simple pain in the joints or lack of mobility. And again, that could be any number of conditions that cause that. Okay. So with that sort of very quick review of the musculoskeletal system, the first case study I have here as part of our review is a resection of a rare metacarpal distal condyle osteoid osteoma. Right? And in this case, we have a 35-year-old male who presents with chronic pain at the head of the second metacarpal bone of his left hand and has had this pain for the last 6 months. Other than that, he'd had hand trauma 7 years ago. The pain increases at night and appears to be partially alleviated with aspirin. And when we look, as you see here in these slides, both the x-rays and the scans, we can certainly see that there is swelling at the second metacarpopharyngeal joint. And again, obviously, it is impeding the mobility and causes some pain. And again, this is supported by both the x-ray and the MRIs. So what's your initial diagnosis? Well, given that we see a mass, again, we would assume it may be an osteoma because, again, because of the symptoms of the pain predominating present at nighttime and can be alleviated with aspirin. Other than that, again, that seems to be one of the easiest things. So again, differentiating between this and an osteoblastoma. Now, the patient undergoes a bone resection and they remove it. It's a little hard in this sort of tissue to kind of get an idea of size. They don't really mention the surgical size, I think, in that paper. I couldn't find it. But what seems to be a little uncharacteristic is that, again, it seems to be rather large for an osteoma. They're typically rather small tumors. So at least from these pictures, it looks kind of on the large size. Okay. But again, histologic examination now shows us again that we see in this case irregular trabecular bone. It has vascular tissue, again, as we see here in the histologic section. So there's a diagnosis as this is an osteoid osteoma, and the patient eventually recovers well. So important for this, again, is patients presenting with bone pain and mobility limitations. You have to be able to decide, is it an inflammatory condition? Is it, in this case, probably as dictated by imaging, that there was a mass present? How would the patient present then differently with other types of bone tumors? Well, again, the big thing with an osteoma, and again, I'm lumping the whole group of osteomas with the subgroup of osteoid osteomas together. And then again, these are benign tumors that generally make rather normal looking bone, although it may be somewhat inflammatory looking bone, compared to the patients who would present with osteoblastomas. Again, their overall clinical presentations, osteoblastomas will have more persistent pain. The location of these tumors, again, may vary anatomically. The giant cell tumors, again, have more persistent pain. They have a tendency to occur often, typically are larger. They can occur in females, often as a result of their growth into the bone marrow. You see a reduction in hematopoietic activity, so patients often will present with repeated infections. Osteosarcomas, on the other hand, remember there, of course, there's going to be pain. So all this is pain and joint immobility. This, again, will occur, again, typically in young males, different mobility. And, of course, one of the things we saw there was this might be associated with what we see the Codman's triangle. So again, we've listed kind of here, I've tried to list, what would be, if a patient showed up, what might differentiate some of these different conditions. But again, they're going to usually take some kind of imaging or histological resection to examination to know what you're looking at. Okay. So again, what are the differences? I think I tried to summarize them here. Tell me if I'm going too quickly. The osteomas may have sort of reactive but normal bone. Again, this is going to depend on, there's an intact periosteum. The osteoblastoma, still localized, there's tissue destruction. Giant cell tumors typically involve the bone marrow. Osteosarcomas, the big key here on the x-rays, you're going to hopefully see Codman's triangle. And an osteochondrome, again, this is going to be a cartilaginous tumor, that this is benign, again, intact periosteum, as well as an endochondral cap. But its malignant counterpart will often have a lot of hyaline and sort of mucus type cartilage production, has a popcorn appearance. And a lot of the bone cysts are going to be, of course, have intact periosteum. They're typically well circumscribed but fluid filled. Okay, so and in addition to this, how else can you discern among these various kinds of bone tumors and tumor-like conditions? Well, some of them we know actually have some molecular and genetic features that will distinguish them. So for example, osteosarcoma often are associated with p53 and RB mutations, whereas chondromas are often associated with inactivation of tumor suppressor gene X1 and X2. Rheumatoid arthritis, we see a lot of ankylosis, and you may be able to measure high levels of autoimmune antibodies. Gout, we talked about the different types of gout as determined by the kinds of crystals that accumulate in the joints. And of course, the big problem here is that while gout can be treated, true gout can be treated pharmacologically, pseudo-gout cannot be. Though rare, again, infectious arthritis, again, we often will see evidence of inflammation, and often you may be able to see serum antibodies to the infectious agent. Typically, how would you rule out the possibility, again, that a lot of these tumors, although it sounds like there are a lot of different kinds of tumors that can occur in the bone, in fact, outside of sort of these benign bone tumors that occur, excuse me, more commonly in young men and male children, we most commonly see cancer of the bone as metastatic spread of cancer from another part of the body to bone. So how would you rule out the possibility of a patient like this having metastatic bone disease? You would have to do a whole body MRI or PET scan to rule out the possibility of other disease elsewhere. Right. So, and not surprisingly, in a background where you have any kind of condition, benign or malignant, that decreases the integrity of the normal histological architecture of bone, you're going to increase the fragility of bone. And so I tried to think of conditions where might you then, as a result, see pathologic bone fractures. And as I tried to list here, maybe you can find some others. We see a number of conditions. Some of these are congenital disorders. Some of these are acquired. Some, again, as a result of, again, disease, benign or malignant tumors, can erode the material of the bone. So as a result, the integrity of bone is lost, and you increase the risk of pathologic bone fractures. Pathologic bone fractures, again, should be, I think you can tell the difference between those and the more common bone fractures that occur as a result of some kind of trauma, where you can get rather simple, complete bone fractures, open bone fractures, where there is, again, usually open to the environment, and that causes potential risk for infection. And we can get displaced bones. Some of you runners out there probably may have had stress fractures in your feet. But in the repair process of bone, try to think about that repair process similar to what we saw in connective tissue repair. When we see a fracture in bone, there is often a little bit, there's damage to tissue, often a little bit of bleeding, even of the small vasculature that's there. So not surprisingly, like you might see in connective tissue repair, in bone repair, there's going to be a clot formed, and there will be, as a result of the initial repair, the formation of sort of a framework, sort of provisional bone material called callus material that is later remodeled into mature lamellar bone. And that is rather similar to the formation, again, of that granulation tissue that we saw that can remodel into scar tissue when we're looking at connective tissue repair. So think about that in terms of their comparisons. Body, if a system works, they just reuse it in other places. So it's not that different a process in bone terms of bone repair versus connective tissue repair. The risks of fractures to bone increase the risk for fat embolisms because, again, a lot of fat is stored in the bone marrow. We don't just have hemopoietic tissue. We often have fat stored in the bone, and this is, again, even more important in young children, where they have a more fat stored in their bones. So again, we often, even though clinically it almost is usually not significant, there's almost every time a bone is broken, there is some release of fat from that bone. So there is the potential for fat embolism in any condition of a bone fracture. All right, in my second case, any comments, concerns about what we just talked about?
I had a quick question.
Sure, go ahead.
When comparing stress and pathologic fractures, is one more easy to repair than the other, would you say?
Well, usually stress fractures are very easy to repair because you don't do anything. You just, because it's such a small hairline fracture. In fact, most stress fractures are missed on a lot of first go-round x-rays. So stress fractures are so small. Again, they're usually as a result of typically trauma. So you usually get them in your feet. Runners who keep pounding the pavement typically get them in their feet. And all you can do is, simple rest will cure those. Pathologic fractures, again, is a result of some kind of disease is eroding the bone tissue. So you can imagine, depending on what that pathology is, again, there's often no way to permanently fix that. So any of these conditions like osteogenesis imperfecta or hyperparathyroidism, these are conditions that erode the bone, and it's going to be hard to get a handle on that, and you can't often replace the damage in a pathologic fracture. So you can get a big divot that forms in the bone in a pathologic fracture. Does that make sense?
Yes, thank you.
Okay. Anything else? All righty then. So let's talk about a little bit of cartilage and bone. Looking at some of the soft tissue, I found a nice article on a heel lipoma mimicking plantar fasciitis in a ballroom dancer. And in this case study, we have a 64-year-old female ballroom dancer who presents with 8 months. She's had left heel pain at first step. That means as soon as the first time, after resting, she steps on her foot, it really hurts. All right. And in the past, physicians have diagnosed her with plantar fasciitis. That in case was unresponsive to the typical treatment, which is usually, again, immobilization, rest, and treatment with anti-inflammatories and sometimes some steroid injections. Now, this patient also has a history of hypertension and osteoporosis and osteoarthritis because she is 64 years old, and somewhat in the background also some thyroid dysfunction. And the physical examination along the medial aspect of her heel, when you touch it, it hurts. And when she walks on it, there's a little tenderness when you touch it. There's no big obvious mass that you might see that you might think of as a big tumor, But what they say, there's a palpable fullness over the medial heel. Meaning it just feels a little thicker than either the contralateral heel. Now, remember, this is a 64-year-old woman, so who's had a whole lifetime of ballroom dancing. So there's been she's a 64-year-old woman who, not surprisingly, has, again, osteoporosis and osteoarthritis. but a whole career of a ballroom dance. I mean, she's been putting trauma onto her feet for any number of years. So initially, if you don't know anything else about the condition, it's really hard to rule out any other, other causes of her heel pain. I mean, we know we'll find out that there's a lipoma, but her presentation could be as a result of arthritis, maybe stress fractures. So you can't rule any of these things out immediately until you do, again, imaging. And certainly this is where disorders of the musculoskeletal system do benefit a lot from all our imaging technologies. All right, so what is plantar fasciitis? Remember, there's a difference between fasciitis and fibromatosis. In the fasciitis, typically, in the case of the foot plantar, it's going to present on the sole of the foot. The area may be a little swollen, it's going to be tender. The patient may limp. In fascia and fibromatosis, on the other hand, remember the biggest thing is, again, patients will they're going to have, if it's on their feet, their feet may be a little swollen, they're going to limp, it's going to hurt, but histologically is how we tell the two apart, with fasciitis showing a lot of cellular proliferation and inflammation, whereas fibromatosis, you actually see a tremendous proliferation not only of the fibroblastic connective tissue cells, but you see a big deposition of collagen. So you see a lot of dense, if you look here, a lot of dense connective tissue compared to here connective tissue that is really maybe mostly made of a lot of just cells with a lot of sort of space in between. And here you can see the arrows are showing you dividing cells again. So those are, again, the metaphase plates. So again, just try to, what are some of the anatomical differences, again, in trying to compare these conditions of arthritis and rheumatoid. And I try to put some of them down here. I hope I've got most of the important things. Again, osteoarthritis itself is just joint wear and tear over age. It occurs typically in older individuals, both male and female, so there's no gender distinction. Typically, patients will show up with some joint stiffness, but when you start to move, if you look at some of your old relatives, once they start moving, then their joints sort of work a bit, but as they sort of use that joint too much, then the pain will come up. They have something called crepitus. The joints will crackle a little. You can actually hear the joints moving a little. And this is to be distinguished from rheumatoid arthritis, which is a very progressive autoimmune disorder that often presents in females who are younger, usually in 20 to 40 years. There again, we'll have joint stiffness and pain, but slowly with that, of course, there's going to be fusion of the joints. Infectious arthritis is going to respond to antibiotics, and gout, as we talked about, we can either talk about pure gout, which is, again, most commonly occurs in a little bit older men with characteristic accumulation of uric acid crystals in the joints. And again, this is usually limited to a lot of the peripheral joints. And TGCT, again, is going to show enhanced production of macrophage colony stimulating factor. It's typically painless, it grows slowly, again, well circumscribed with benign tumors. So how, again, it's important to differentiate, again, all these patients showing up with joint pain, what it is, because you're going to need to treat them differently. So for example, with typical arthritis, really you can only do anti-inflammatories and maybe some painkillers. Rheumatoid arthritis does also benefit, in this case, sometimes with steroid, with other agents such as methotrexate, which will reduce, the idea here is to reduce protein synthesis and reduce the production of autoantibodies. Hydrochloroquine, which was actually a drug used in malaria treating, again, seems to halt some of the progression of the disorder. And then there are other things like making antibodies to TNF. So infectious arthritis, on the other hand, usually responds well to antibiotics if the pathogen is a bacteria. And as you mentioned, the true gout responds generally well in its early course with things like allopurinol, which prevent the production of uric acid crystals and their deposition. All right. So again, I'm trying to think about, in general, when patients show up with sort of joint pain, there are any number of things that can be going on. So you have to use imaging as well as the patient presentation. and their characteristics to try and be able to decipher which kind of disorder they have so that you can treat them differently. So if we go back to our patient, her x-rays were normal. Sorry, this picture is a little small, but when we see on the MRI, we see these beautiful, really well, solid, encapsulated, very homogeneous mass here that, again, it presents, in this case, by x-ray, we can tell this is a lipoma that is compressing her hallucis muscle and the plantar nerve, which is giving her some of the pain. So how would she present if this, in fact, instead of a lipoma, we see this sort of big solid structure? If it was a cyst, in this case, we would probably see it within the ankle, not maybe quite within at the heel, but in the ankle, and maybe could be painless. You might see tingling. Again, there may be compression on a nerve, but of course, it would be fluid-filled rather than solid. And who is at risk for, again, some of these disorders? The risk factors for, again, certainly cysts are going to be a background of osteoarthritis. And again, all of this, even the lipoma is in the background, the risk factors for, again, repeated trauma. She's been pounding her feet on the ballroom floor for a long time. And in contrast, remember there's a condition that we call tarsal tunnel syndrome. It's kind of like carpal tunnel syndrome. Patients will present with sort of often numbness downstream or either in the hand or in the foot, depending whether we're talking about tarsal or carpal. And that's usually because of compression of the medial or the posterior tibial nerve. Often when we get these tunnel syndromes, there may not be a lot of swelling, but again, there's pain that, again, is usually alleviated when we often sort of surgically remove whatever is impinging. So there's going to be a difference, again, x-rays, think about what a lipoma would look like versus a ganglion cyst versus simply compression of a nerve, even possibly due to inflammation within a joint. So again, in our patient, she undergoes surgical excision of the mass. Here, you pull it out, and it just looks like a big, beautiful blob of fat globules, right? And so what we see histologically when we look at it is just a mass of very mature, consistently normal-looking fat cells or adipocytes that have a little bit of sort of fibrous connective tissue separating out lobes of the sort of fat lobules. And so again, that's what it looks like. So the confirmation of the diagnosis is a lipoma, which is a benign tumor of fat cells, and the patient recovers completely. Now, would she be concerned that this condition, if she was left, would it have progressed to malignancy? Absolutely not. These are, again, benign conditions, these lipomas, like a lot of benign tumors. The only problem they can cause is with time, they may just get so big that their bulk impedes the function of nearby tissues and organs. But again, these do not progress to a malignant transformation, to a malignant condition. If this had been a malignant condition of fat, we would have called that a liposarcoma, correct? Okay. All right. So in terms of other soft tissue disorders, again, we have the lipomas and liposarcomas, which are tumors of fat. These are different from leiomyomas, right? The leiomyomas are tumors of smooth muscle tissue. The leiomyoma is a benign tumor of smooth muscle. Most commonly, we find this in the myometrium of the uterus. Unfortunately, the most common word for these benign leiomyomas in the uterus and the myometrium of the uterus are called fibroids. And you've probably heard that term. There is nothing fibrous about them. They are smooth muscle tumors. The term is a bit of a misnomer because of the, and I guess it arose from the original sort of surgical and histological examination that when you pull these leiomyomas out of a person, they are rock hard, solid balls of mass. So people thought, in fact, that they were full of connective tissue rather than smooth muscle. But again, the leiomyomas is, again, the clinical term for a fibroid. So the malignant version of, again, a leiomyoma is going to be a leiomyosarcoma. Sorry about that. And again, like the lipoma is not a precursor for a malignant counterpart. If you're going to get a malignant tumor of smooth muscle, it will initiate on its own. All right, so instead of this patient having a leiomyoma, or a lipoma, sorry, if she had in fact had a malignant tumor in the actual skeletal muscle, what would you call it? And that would be called a rhabdomyosarcoma. Again, sarcoma because it's of the musculoskeletal connective tissue, and its intermediate filament that would determine it would be desmin. And I'm bringing back to you using your basic intermediate subtypes as representative of different tissue types. These are the features that we often stain for to determine the tissue of origin. So remember, we use keratin intermediate filaments to determine if a cancer is of an epithelial origin. We use vimentin if it's more connective tissue, and we would use things like desmin staining patterns to see if it's positive. Then that would be an indication of a tumor of skeletal muscle. Right, so we got that as muscle. So remember, this is important. That basic histology is simply your intermediate filaments, again, are really important diagnostically. Within these sort of groups of some of these tumors, we have some unique cells. And one of these that I've told about here is the strap cell. It looks like a little tadpole cell. Again, it's characteristic of a rhabdomyosarcoma, again, with that cell type called the rhabdomyoblast is its origin. So I've tried to think again, remember your different odd little cell types that we see characteristically. Think about how a strap cell is different from a Sternberg cell, from a signet ring cell, or even your simple adipocyte. A lot of these look like big round cells. Some of them may look like they're just empty or full of fat. They're going to be they may be somewhat similar, they may be different, but again, they often are associated with very specific conditions. Okay. All right. So if this patient had presented with damage to her skeletal muscle, she might have presented then with the condition we call rhabdomyolysis. And that is basically rupture of skeletal muscle that releases myoglobulin around into the tissue. That is not the same thing as hemorrhaging, but if you found that in the tissue, then you would be again, that's indicative of skeletal muscle damage. And had there been significant, though, tissue damage, let's say, in her skeletal muscle, in addition to rhabdomyolysis, we would have had that damaged tissue again undergo an inflammatory condition, with the removal of the damaged tissue, and you might consequently, in the whole process, see an accumulation of hemosiderin in macrophages. So it's a different kind of sort of pigment or the deposit, and again, it's usually sort of yellow to brown, iron containing, again, and it's usually again found in macrophages that are digesting damaged tissue away, again, as again its presentation again usually of sort of cleaning up some of the blood elements. But I tried to list then, so I'm thinking about this in terms of the release of myoglobulin with rhabdomyolysis and hemosiderin. What are other kinds of both intra and extracellular accumulations of sort of proteins and things that we have seen? So some of the intracellular accumulations, go back and remember and think about where you would find Mallory-Hyland, where you might find fat deposits, copper, lipofuscin, just carbon, where might calcium be deposited, under what conditions do we consider, for example, metastatic calcium deposition? Where do we find hour rods, those Howell-Jolly bodies? And likewise, we have accumulations of substances that can be outside of the cell as a result of disease or damage. And we've already seen things like amyloid plaques. Again, calcium deposits can be intra or extracellular. Pus in and of itself is an extracellular accumulation. Keloid material, where our famous keratin pearls, and even edema represents an extracellular accumulation, in this case of fluid. All right, I'm trying to help you bring concepts and thoughts together. I hope this is helping. Are we okay so far with that?
Yes.
Okay, great. All right, so let's move on to the male reproductive system. Again, we're using, taking those same ideas of what kinds of things cause disorders, congenital anomalies, infections, inflammations, cancers. And so I know I did a big review of the male reproductive system in the first part of that lecture, but really what we're looking here is we're going to have some congenital anomalies. In this case, a lot of inflammatory conditions, with a lot of these inflammatory conditions as a result of infections. And then, of course, the male reproductive system is prone to both benign and malignant tumors. But as we're going to see, oh, I guess that was my short review. Boy, think about this compared even to the musculoskeletal system. Here, when we think of a lot of the congenital anomalies that we listed in this lecture, things like all the different malformations of the penis, we can get duplication, webbed penises, hypospadiasis. A lot of these, again, are rather sort of gross anatomical malformations. They are unlike sort of the point mutations that give us things like achondroplasia or osteopetrosis, where we see one single point mutation. So a lot of these congenital anomalies in the male reproductive system are not inherited conditions like we saw in the musculoskeletal system. So again, what we see are, again, a lot of congenital anomalies that luckily respond very well to surgical intervention. But again, we see a lot of inflammatory conditions as a result of infection. And key to the male reproductive tract, again, is this is a system that is made up of a lot of small tubes that run long distances. So anything that is sort of a tubular structure is going to be at risk of one being obstructed, either as a result of inflammation or infection, and that's going to impede reproductive function, as well as potential urinary output, because in the male system, again, there is such a link between both the reproductive and urinary tract. And likewise, all of these duct systems and the tissues are lined by epithelium that again can be at risk for a lot of them for undergoing malignant transformation. And the difference with that will be then within the scrotum, in the testes, we have germ cells that give us unique tumors in the male reproductive system. So if we look at our first case, again, highlighting in the role of infections to cause inflammatory conditions in the male reproductive system and how the consequences get extreme, right? Our case is a case of syphilis. And this is an atypical case of sepsis and multiple anogenital lesions as a result of secondary syphilis. So we have a 22-year-old male with really no significant medical history other than he shows up with, of course, a fever, chills, and a sore throat, diarrhea, and excessive sweating. He, again, so during examination, you can see that he has a fever, a little tachycardia, he's hypotensive, well, he's nervous, he's in the ER. And we see some diffuse lymphadenopathy in both the cervical and tonsillar regions. So again, there is some kind of lymph swelling indication, typically that there's some kind of inflammatory event. There is, however, no inguinal lymphadenopathy. There is purpuric rash on the extremities of the soles of his feet. And initially, the patient, of course, is a little embarrassed, so he refuses genital examination, but later relents. And there we see a number of papular, non-pustular scrotal lesions that are, some are in healing, some are a little non-tender, they are irregular. And again, the patient then kind of concedes that he has tried to self-medicate for the past week, trying to alleviate lesions on the penis, and attests to the fact that he has had high-risk sexual behavior with other men. So your initial diagnosis, well, you would, based on what you see here, certainly there's some infection going on. Given the history, you probably would be suspicious of some kind of sexually transmitted disease, and that is sort of causing the lesions present not only in the genital area, but explain the systemic symptoms. So we sort of see, again, that this. Now, what are the common sort of things? Again, this, I'm sure you're probably already familiar with. The most common types of STDs that we deal with, clinically, are things like chlamydia, gonorrhea, herpes, HPV, hermaphilis, and some of that soft canker, so what else? And that. So Again, what are some of the characteristics of these? Luckily, the ones that are, as a result of a bacterial infection, again, sometimes they all have usually pretty distinct presentations, either because of their lesions or the discharge. And certainly with a lot of the bacterial infections, we may or may not be able to actually collect the bacteria from the lesions and find very test positive. And again, luckily with most of these, even though patients are hesitant to come and see you, if they are as a result of bacterial infections, a lot of them can be very easily treated and cured with antibiotics. But we have, again, some certain characteristics that we know with them. Again, what is interesting, pardon, I don't mean to be disrespectful, but both chlamydia and gonorrhea will often show up with a white, creamy discharge. And again, one of the things that is common, they may have some kind of, in chlamydia, you may sort of see some neutrophils. You typically don't see the bacteria present in the discharge, all right? They may present with a very specific lesion, that venereum lesion. On the gonorrhea will present with, in that white creamy discharge, usually you start to see the bacteria, and the patients, of course, may even be asymptomatic. For both that and chlamydia, which is why a lot of these diseases progress or pass along so easily. On the other hand, people with things like herpes infection, this is viral in its course. You see little small pustular lesions, and within those lesions you find those Codry type A inclusions. The soft canker sores are different from the syphilis hard canker. And again, even though we have all of these different types of STDs, the one that really is concerning for its possible transmission into malignancy are infections with the high subtypes of HPV. Okay, and I put this in here. This is our, so I'm sure you've reviewed this. How would you tell which is which? And I think you can probably identify, again, the hard canker, the initial sore of syphilis, to be kind of differentiated from the soft canker core, or the canker core with a CANK that goes times in your mouth is completely benign. They usually resolve even though they're painless. All right. You usually get some little papillary structures, often with HPV. This often looks like kind of herpes little sores. And again, sort of the white creamy discharge can be as a result of gonorrhea or chlamydia. This sort of depends on whether you can find bacteria present or not. One feature of syphilis is that it has a very distinctive course that starts off with sort of the hard canker sores, and then there is progression of infection systemically, so that later on people show up with lesions and rashes at other parts of their body. And then in final, sort of more advanced stages of syphilis, we get these big, horrible lesions that we are appropriately called gumas. And again, they're sort of very inflammatory. But in, again, a lot of these conditions where there are bacteria or viruses present, a lot of these in these sort of open lesions where the bacteria or viruses are present, that can, again, influence the degree to which the disease can be communicated and transmitted to other individuals. So in our individual, lab tests indicate leukocytosis. That means there's an increased number of white blood cells. So not surprisingly, you're dealing with an infection. There is a little bit of elevated creatinine indicating renal dysfunction. Not surprisingly, again, in the male reproductive system, if something starts to obstruct any of those tubes, particularly the urethra, the patient can present with urinary problems. Eventually, other tests are certainly positive for, again, the bacteria causing syphilis, although the patient is negative for all these other kinds of STDs. So the patient's diagnosed with secondary syphilis, again, because they have not only the lesions on the penis, hard canker, but again, those rashes on their hands and rash on their feet. The patient initially, though, surprisingly sort of undergoes, and again, this is the idea where initially catching these things early can be easily treated. And this poor patient, he ends up going into septic shock because of the excessive systemic infection. But initially, and he does eventually, he's hospitalized and he's treated, and he does make a full recovery. So certainly, what are the consequences, again, to both the male and, in case indirectly, certainly the female reproductive tract? with prolonged STD infections? Well, certainly we're going to see that these chronic or repeated infections, again, can not only impede urinary infection and cause urinary tract infections, but in sort of both genders, you can see the potential for obstruction of reproductive flow and function. And again, we will certainly see potentially the spread of disorders from one individual to another. So that was all I wanted to talk about. Sort of a lot of, again, think about, again, infectious diseases in the male reproductive tract, see how many there are and how they can simply, again, simple bacteria can cause severe renal dysfunction. So again, a lot of your patients may show up with renal dysfunction, pain during urination. Again, these are sort of very general symptoms. It's hard to figure out what is, again, at the root cause. So in this is our last case study. Oh my gosh, we're going through this. Next case study. All right. I know this may be the more difficult thing. It's entitled Cutaneous and Systemic Metastasis of Testicular Choriocarcinoma. So in this case, we see an 18-year-old boy who presents initially with bilateral chest pain. Typically, what would you think of when you think of chest pains? Remember all our lecture on hemodynamics. You think of chest pains, you think of myocardial infarctions. In an 18-year-old, you might think of trauma to his chest. You're not initially thinking that the chest pain would be as a result of a metastatic spread of a cancer. But physical examination sort of shows, again, this sort of dark pigmented area. And even when you look at it how it is irregular in its presentation. All right, it's sort of a little dark, a little pink, a little white, and the shape of it is outlined is irregular. So as we talked about neoplasms, that doesn't look like something that would be benign if it was in the tumor family. Obviously, that irregularity would be suggestive of something more malignant. Okay. Likewise, there is, when during on exam, we see a non-tender mass present on the left testes. When we do CAT scans, we start to see, unfortunately, look at all of these metastases, both sort of all through the lungs. All right, so that's not looking very good. So now we're seeing sort of masses all up throughout the body. Our serum markers are all normal except for exceedingly high levels of human chorionic gonadotropin. Okay, at 10,000 units, this is way above normal, which should be basically less than around 5. So not surprisingly, just based on this alone, you can make a preliminary diagnosis of metastatic choriocarcinoma from the testes. Again, because these particular cancers have high levels of serum alpha-fetoprotein. All right. And I hope that everybody understand the different kinds of, cancers that arise from the germ cells in the testes. This is not anything to do with the Leydig cells or Tolle cells, not from the connective tissue. It is simply from those initial, shall we say, spermatogonium in the testes. They can undergo malignant transformation. And so as a result, we have different types of what we call testicular cancers. The seminomas and the spermatocytic seminomas, typically, again, older men, really no big significant serum markers. The one nice thing about these sort of seminomas is that the cells forming them are generally very homogeneous. And even though these are malignant cancers, they grow well circumscribed, they are very firm, so they generally grow a little slowly, so they have a generally good outcome. On the other side, we have the embryonic carcinoma as well, excuse me, as the yolk sac tumors. These start to occur in earlier individuals, particularly the yolk sac. And again, with serum markers, the yolk sac cancers are the ones that have high levels of alpha-fetoprotein, and they have that distinctive Schiller-Duval sort of roseate group of cells within the cancer mass. Now, both of these will start to sort of erode some of the nearby tissue, so you often see some necrosis and hemorrhaging. But again, they typically respond very well to treatment so that the overall outcome is good. So again, in terms of how we look at them as how do these cancer cells mimic their normal downstream developmental progeny of the stem cells in the sperm. So we think these seminomas themselves are what would be, if they had been normal, they would have given rise to next generation sperm. The embryo carcinoma cells leave a lot of fetal body parts and stem cells, whereas the yolk sac are, in their histology and their behavior, mimic a little bit of organs that would be part of the hematopoietic system. The ones that are really of concern in testicular carcinomas of the germ cell are what we call the choriocarcinomas. They again occur in relatively young men. These are associated again with high levels of HCG. There are a lot of large sort of fused cells, a tremendous amount of hemorrhaging and necrosis in the tissue. And even though they are relatively small in size, they are aggressive, and sort of their ability to invade, it mimics in a way the behavior of the embryonal cells that form the placenta. I'm sure you learned in embryology how the placental cells that form the placenta are derived from the embryo, and they are really very invasive into the mother's myometrium. So if you think about these choriocarcinomas as mimicking that invasive, almost alien-eating features, okay, of like a placenta, you can understand why they're very aggressive and they respond poorly to any of our therapeutic procedures. And lastly, of course, we have the teratomas. Our picture. These are so ugly that they are gorgeous. They represent, there's both a benign teratoma and a malignant teratoma. Unfortunately, we use the same name for both of them, really. They occur at any age. They really don't have any markers, but what is important with these is that within the feature of the malignancy, you see derivatives of all three germ layers. So that's really important in both the benign teratoma as well as the malignant teratoma. So let's go back to our patient. When they take a biopsy that confirms the presence of choriocarcinoma, they remove the entire left testes, and again, further examination confirms this is a choriocarcinoma. So not surprisingly, as we saw in the slide right here, the choriocarcinoma, large, big, sort of fused cells, lots of hemorrhaging and necrosis. So when we look at the tissue, it's hard to see on this histology that it's made of a lot of big cells. In the core of this oligo is hemorrhaging and damage, all right? So again, not surprisingly, the biopsy is going to be negative for alpha fetoprotein, vimentin, really, and even keratin, because it's really not of those derivatives. We unfortunately see metastatic spread, all right? And the pathology in this case is sort of, he is diagnosed as T1N2M1. Remember, again, we use that TNM staging system for a lot of cancers. And so in this case, T1, it's a little different. It means in the testes that the size of the growth is sort of outside the testes, is going in with N2. We're looking at nearby lymph nodes, and M1, of course, indicates metastatic spread. And unfortunately, our patient did not survive, again, probably because of the extensive metastatic spread. So even though he tried some chemotherapy, he underwent multiple organ failure and died. So again, if this had been a cancer other than a, not a germ cell tumor, and it had presented on the genital skin, it would be a squamous cell carcinoma. Remember those? And how do we differentiate those histologically? Well, of course, they're going to be, because they're from skin, they're going to be not only keratin positive, but we're going to see those keratin pearls that are distinctive of squamous cell carcinoma. If this instead had been a biopsy taken and it was vimentin positive, what would it be? Of course, it would be a sarcoma. So I'm bringing back that idea of the intermediate filaments as helping you determine what tissue type is the origin of the cancer. What typical conditions increase the risk for developing testicular cancer? Again, a history of family disease, but also undescended testes. When the testes remain in the abdominal region, they fail to, again, be in their normal environment, which is outside the body at a lower temperature. And so within the abdominal cavity, the different temperature, as well as the potential microenvironment of different hormones and growth factors, again, can cause those undescended testes to develop irregular and inappropriate growth, which can cause malignant transformation. Now, what other conditions might present as an enlarged testes? In this case, we had testicular cancers, but we can get sort of large, sort of fluid-filled scrotum that are either hydroceles, hematoceles, or chyloceles, depending on what is the characteristic of the fluid within that scrotal fluid. One other thing that can occur is the presentation of testicular torsion. How would you know this? This usually occurs in adults and is characterized by absolutely incredibly sudden, I mean sudden onset pain due to the torsion of the spermatic cord, which causes infarction to the testes. You need to, these require immediate surgical intervention to prevent permanent infarction, damage, and necrosis to that testes. All right. Oh, we have one more case. I forgot about that. So again, when we think about the male reproductive tract, so even though we talked about these testicular cancers, they're not in reality that common, right? Usually within the male reproductive system, we're going to get infections and such, or anatomical abnormalities that compromise the normal reproductive function or urinary flow. When we're really thinking about sort of tumors or growths in the male reproductive system, really what we're focused on, the most common area is the prostate. And we can get a benign condition called benign prostatic hyperplasia, or we can get prostatic carcinoma. These are two separate entities. They are not related to each other. All right. So in this last case study, we have a giant benign prostatic hyperplasia in a young adult male. All right. So here we have a 27-year-old Caucasian man who presents with lower urinary tract symptoms and some blood in his semen. All right. Again, that alone, urinary tract symptoms can be any number of things. Think about all the potential infections or potentially even anatomical aberrations that can impede normal urinary flow. He does, however, have a relatively high PSA level, but the semen that is cultured is sterile, meaning there is no infectious agent present. On digital rectal exam, there is noted that there is an enlarged but smooth prostate, right? And that may or may not be easy to find an enlarged prostate on the digital exam based on the anatomical regions of the prostate. And an MRI, as we see here, starts to show, again, the enlarged prostate. Here's the part of the bladder, here's the prostate. The normal prostate is about the size, if you were to stack 3 pennies together, that's about the size of the normal prostate gland, right? For reference. So in this case, we see, again, ultrasound reveals a little homogeneous adenoma in the peripheral zone. Again, what are urinary tract symptoms? Well, again, these are the kinds of things that can occur. Avoid difficulty voiding urine, a hesitancy to void, intermittent stream, feeling that you don't completely empty your bladder. All of these things, again, are what we call sort of lower urinary tract symptoms, but they can occur as a result of an infection or benign, again, prostatic hyperplasia. We are suspicious of PSA levels that are anywhere over 4 nanograms per mil, although PSA is not the perfect marker, it is somewhat helpful. Again, with regards to the anatomy of the prostate, when we do a digital rectal exam, really the outer zone, the peripheral zone of the prostate is what is best palpated in this exam. And the good thing with that is, of course, that's where the carcinomas have a tendency to arise from. So digital rectal exam is, again, good at detecting carcinoma. Okay. So in our patient, all right, they perform a biopsy and they say, of course, oh, there it is, benign prostatic hyperplasia. When they eventually take out the prostate, again, this is a very difficult procedure to do because of the fact that the prostate gland itself forms, so to say, multiple connections to the urethra. It's like it attaches and connects to the urethra by multiple little ducts and tubes. So if you try and sort of tear off or cut off the prostate from around the urethra, you always run a huge risk of tearing the urethra. So that is why prostate surgery is often the last option that we consider, because of the high risk of then incurring urinary incontinence. But in this individual, his prostate was so enlarged they had to take it out, and it weighed 181 grams. I'm trying to think what that is. That's sort of probably the weight of your coffee mug, half a can of beans. I mean, it's rather large if you compare that to 3 little pennies. Now, what's the histologic appearance? Well, again, it's benign prostatic hyperplasia. So you're going to see a lot of what looks like almost normal glandular appearance, but you just start to see a little hyperplasia, again, of the epithelial component. There may be, again, some additional stromal hyperplasia, there's some growth of the plasia. But again, the lumen may, because of the exacerbated growth of the epithelium, is producing a number of the nutrients that are found in semen. So you might start to get sort of the lumen have a sort of viscous material that they call corpora amyloica. So again, please remember that benign prostatic hyperplasia does not ever progress to prostatic carcinoma. They originate separately. However, for the males out there, the bad news is if you all live old enough, you will probably get one of the two of the disorders, all right? That benign prostatic hyperplasia is extremely common in elderly men, as is prostatic carcinoma. But luckily, prostatic carcinoma has a tendency to grow very slowly, so that often patients succumb to other conditions other than prostatic carcinoma. Again, all right. So if this patient had presented with an enlarged prostate but normal PSA, what tools, diagnostic or treatment options would you consider? So remember, there's one option that is always sort of spoken on the table, that you don't do anything. But however, in our litigious society, the least that you can do for any prostatic condition, whether that's benign hyperplasia or malignancy, is at least monitor the PSA levels. This may give you an indication if the PSA levels continue to rise that you may need to then use some other intervention. So then you can otherwise treat. If the patient has problems, again, with urinary, you can probably sometimes use muscle relaxants to help the urine flow. But these benign prostatic hyperplastic lesions are usually all very androgen dependent, so they respond very well to anti-androgen therapies. So if we think about this patient who has benign prostatic hyperplasia, if in contrast he had been diagnosed with prostatic carcinoma, a relatively young age with high PSA, what would you recommend? And again, we have different options as to how we treat patients with prostatic carcinoma. Again, doing nothing is not an option. The very least you will do is monitor the PSA levels. Again, this is particularly in patients who are young, so you don't want to destroy the tissue with any intervention if you don't need to. The PSA levels, again, are relatively low. There's no metastases, mild symptoms, even if there's small malignancy present. You kind of just monitor the PSA levels, because the odds are this grows so slowly that it won't be clinically significant for many, many years. On the other hand, we have the option of radiotherapy. This is often given, again, to patients who are relatively young presenting with prostatic carcinoma, who have a relatively smaller, low-grade prostatic cancer, again, with no metastasis. The idea is with radiotherapy, we can shine a very direct beam of radiation onto that growth with the intent to try and reduce the size of that malignancy, basically to shrink it. Other things that can work are things like further anti-hormone therapy. Again, we typically use this when there is metastatic spread, because the simple, a UV zapping can't get to the metastatic spreads where they are throughout the body. Surgery, again, is considered our least and last form of intervention, because, again, it can destroy the structure of the urethra and lead to urinary incontinence. As we had mentioned when we talked about cancer, we talked about the general terms of stage and grade, and we introduced additional staging systems depending on cancer types. with the T and M originating in the breast cancer, but now being applied to many other malignancies, particularly carcinomas. In prostate, we add yet an additional scoring system called the Gleason score. And this is because, again, within a typical prostate carcinoma, the grade of the carcinoma within a prostate can be very heterogeneous. So one area may be a high grade, one area may be a low grade. As a pathologist, if you were simply to say, well, it's a low grade, if you don't report on the high grade, that can influence the outcome and the treatment. So we typically look throughout a prostatic cancer and sort of determine what region represents what is the lowest grade and what is the highest grade, and that's where we add those scores together to give us the summarial score of the Gleason grade score for prostate cancer. Does everybody kind of remember that, get that?
Yes.
Okay, great. Okay, so again, how would you distinguish, again, so now that's how we distinguish a lot of things between benign prostatic hyperplasia and cancer, but other conditions that occur in the prostate are prostatitis, right? That's basically inflammation of the prostate. Now, both of these, again, are all like prostate cancer are going to present, again, with that generic lower tract urinary symptoms. So again, they can compress the prostate gland. Now, prostatitis, again, is associated with inflammation. If there's a bacterial infection, it may respond to antibiotics and you can regress. So that's a little bit different from benign prostatic hyperplasia has no inflammation. There's just this hyperplasia of the normal prostatic glandular tissue. And of the types of prostatitis, remember that we have an acute and chronic, and you can, again, remember what kinds of cell types would typically be present. Interestingly, we have a form called asymptomatic inflammatory prostatitis that is usually not associated with any bacterial infection. And again, the patients, because they're asymptomatic, we never know it. This condition is usually found secondary to something else. Unfortunately, within the types of prostatitis, the most common is called chronic non-bacterial, often referred to as chronic pelvic pain. And unfortunately, because it is the most common and it is non-bacterial, it's very difficult to treat because there's no way to alleviate that chronic inflammatory condition. And no one is still, I think, quite clear as to what causes this condition. So are we okay so far with these sort of overall concepts of the male reproductive system?
Yes.
Okay, great. Sounds like you're the only one out there. Okay, but I'm going for it. All right, I have some sample questions, and thanks to Elizabeth, she found my mistake in this question. We tried to pull some things together again. As a researcher focused on disorders of the musculoskeletal system, you discover a subset of the Florida pediatric patient population that developed two left thumbs. Histologically, both left thumbs in these patients are composed of normal ossified bone. Further, this occurs in family clusters where both males and females are equally affected. And when analyzed over 4 successive generations, you know that 25% of the children in each generation are present with disease. You also discover that the underlying mechanism of the disease results from inactivation from osteoprotegrin, and associated with this, you see antibodies to osteoprotegrin. And there are, as a result of this disorder, complexes of osteoprotegrin antibody that are deposited along the leading edges of the endochondral ossification in the thumbs that seem to somehow contribute to the thumb duplication. So in all of that together, we put a lot of things in here over the course. What do we know about this person? Okay, what is this condition? Is it inherited in an all of this is true, except, is it inherited in an autosomal recessive pattern? Yes, because it affects both males and females at about 25%. All right. Is it a type 2 hypersensitivity reaction? Well, of course, that is the one that is incorrect. The deposition of antibody antigen complexes is a type 3 hypersensitivity reaction. This is an example of dysostosis because, again, we're getting the formation of two thumbs, the second thumb being normal histology bone. And thanks to Elizabeth, she corrected my mistake. This disorder is also associated with increased bone degradation. I apologize for the earlier typo, right? Because the role of osteoprotegerin is to stop bone degradation. So if you remove it from the equation, you're now going to see increased bone degradation. Are we okay with this question? Are we okay with pulling together concepts from all the prior lectures?
Yes, it makes sense.
Yes.
Okay, so we see how I'm going to play with your questions for the final exam. All right, one more here. This is kind of the easiest one. In terms of another way, I want you to think about these conditions. Which of the following is associated with the least favorable outcome? We have hypospadias, melanitis, bilateral cryptorchidism, a yolk sac tumor, a dermoid cyst, squamous cell carcinoma of the scrotum with iliac lymph node involvement. Okay. I think you can probably figure that one out. It's going to be squamous cell carcinoma because it's a malignancy. For the most of these, again, hypospadiasis, we can repair surgically, even if it requires repeated repairs. And again, this is highlighting the idea that a lot of the anomalies of the male reproductive tract can be corrected surgically. Balanitis, again, is an infection of the glans penis. It responds very well. And even when we have the presence of the foreskin, again, if you treat well with antibiotics, infections in that region can be taken care of. Likewise, bilateral cryptorchidism, these are undescended testes. They respond well to removal with surgery. Sometimes if you pull them down early enough, you can get them functioning. The risk, if you don't, is that they're in that abnormal environment in the abdomen. If you leave them in there forever, there's increased risk that you can get malignancy. In yolk sac testicular tumors, like the majority of those tumors of the germ cells, respond very well to either surgical intervention or chemotherapies. And a dermoid cyst, again, is another term for the benign teratoma. Again, responds very well to surgical intervention. All right, any questions, concerns?
Would you say that it would be helpful to review the prior exam material going into this exam?
In terms, if I were you, I just sort of flip through my notes, and I'm not going to ask you very specific things, what gene is mutated in another disease, but I think it's important to try now to put together some of the more common disorders. That's why I try to, what are other connective tissue or musculoskeletal inherited disorders. I'm not going to ask you specifically what the genes are, but again, we have to put this in a more global context. So I think it's good to kind of just sit down one night with your cup of tea or a glass of beer and just sit down and kind of just flip through the notes just to remind yourself what other conditions are related to what we've seen here. But really what I'm really focusing on is the concepts, all right? The big concepts of hypersensitivity reactions, the process of inflammation, how we inherit disorders, Mendelian, autosomal dominant, recessive, all right? What's benign versus malignant tumor. I want to try and pull these things together without just focusing on the little nitty gritty, but by the same token, if we've talked about a disorder here, if it came up before, for example, like trisomy 21, we think about that as associated with, mental retardation, but these individuals also have other potential disorders. They have risk for cardiac disease, they have risk for Alzheimer's. So, what are some of the other disorders that may also relate to these last 4 areas that we've talked about in terms of neoplasia, GI tract, musculoskeletal, and male reproductive. Does that help?
Yes, thank you very much.
Okay.
I just had a quick question about the diagnosis of squamous cell carcinoma.
Okay.
So for the keratin pearls, is that only found in squamous cell carcinomas of skin, or could that be for squamous cell carcinomas of other organs as well, where they don't have keratin, essentially?
Well, they're for all squamous cell carcinomas. So really the only place you find it in the body is, the skin I guess the inner part of your mouth, the vagina. So it's a distinctive feature of squamous cell carcinoma, not keratinized squamous cell carcinoma. Not, you know what I mean? It's not that the fact that you have a lot of keratin on your skin, it's because it's a squamous epithelium, stratified squamous epithelium.
Gotcha,
So,
that makes sense.
so wherever you have a stratified squamous epithelium, if it becomes malignant, it becomes a squamous cell carcinoma, hopefully with keratin pearls that are beautiful to look at. They look like those onion rings. Okay.
Thank you so much.
Okay.
Dr. Kirk, I have a question about the pathogenicity of rheumatoid arthritis.
Okay.
So I'm trying to put together what's happening here. I know there's a difference. I know there's a big difference between granulation tissue and granuloma, but are both kind of occurring in rheumatoid arthritis? Because I know what happens if it's untreated is you get a pannus,
right,
and that's granulation tissue, and then I know you get the RA nodules, and they're a central necrotic core with palisading histiocytes. Is that the same thing as a caseating granuloma?
Not really, because the granuloma is more as a result of, it's similar, I guess, in that you're forming damage to the tissue, but it's not quite the same process, because this is just continuing destruction of the tissue. With the granuloma, you're slowly, hopefully, eventually getting into repair of the tissue. There's no repair here. I'm not sure if that helps you.
I'm sorry, did you say granuloma is repair or granulation?
Granulation is repair. The granuloma is just because you have sort of that core of necrosis, usually because you're trying to wall in an infection, correct? There's no infection here in rheumatoid arthritis. There's no bacteria, there's no pathogen. You are getting slow destruction. There are some similarities. I think that's a good observation on your part, but the overall process is not quite the same, because with a granuloma, again, the intent is that you're trying to repair the tissue. You're trying to wall off the pathogen and then repair the tissue. In the case of rheumatoid arthritis, yes, you have these palisading cells, and it looks like you have a necrotic core, but the idea is that there's no intent to repair this. This is just slowly going to continue to deteriorate. Because there's no...
Okay, that makes sense.
Yeah.
So I know that you do have granulomas in Crohn's disease. How are those different comparing as like the cellular presentation?
Well, in Crohn's disease, you get granulomas because you have an inflammatory event. So you get damage to the gut epithelium. So it's going through the same kind of repair process, usually because it may or may not be infectious. I mean, we do find a lot of infection because there's nowadays we know a lot of disruption of the gut biome. So there seems to be that looks like it's trying to repair the damage and wall off the inflammatory region. But again, the body just doesn't have the appropriate resources or steps to repair completely. So as a result, if the body attempts to repair this sort of inflammatory raw tissue, but it doesn't have the resources to do it. I'm not sure if that's helping you at all.
No, that helps. I know it's a lot of similarities between them, but thank you.
I mean, a lot of it, we get these granulomas again. They're usually again as a result of damage to tissue. We used it in the inflammation, using it as walling off our pathogen. But it can be, again, in extensive damage of tissue, you start to form a granuloma. And it's sort of like a stopgap measure. We're trying to see, can we repair it? And in cases where we can repair and wall off a pathogen, then we can repair the tissue. But in these cases of like Crohn's, you get the granuloma, which is sort of, again, trying to wall off, or sort of is a small area of inflammatory damage. But because the condition is chronic, you keep having the local inflammatory cytokines that just keep aggravating the situation. So you can't resolve the granuloma in these sort of chronic disorders like rheumatoid arthritis, like Crohn's disease. not like you can if you think about just tissue damage or a localized infection in tissue.
Okay, that makes sense. Thanks.
Okay. Anything else? I don't see anything. Anything in, okay, I didn't see in the chat box. Nope, okay, I think I found it. I didn't see it. All right, I don't see anything else. Okay, I don't see any conversations. Okay, any other comments? All right, if not, let me know if you have any problems. I wish we had been in person and seen you, but I appreciate all your hard work. All right.
Thank you very much, Dr. Kirk.
Okay, thank you. Have a good weekend.
Thank you. You too.